Well, hello everybody. Welcome to Nursing That Makes Sense. This is a channel for nursing students and nurses who are practicing nurses already. For nursing students who are learning new concepts in school, this is for you. The idea is to help you study for your exam and to talk about anything related to nursing and making it as simple as possible for you to remember when you're taking an exam or when you're doing your clinical training. And then for nurses like me, this is actually a refresher course because it's been a while, right? So we're going to be talking about the basic metabolic panel, and we are still on the calcium electrolyte. So in the previous slide or in the previous video, I talked about the hypocalcemia. So this time I'm going to be talking about hypercalcemia. So before I go to that particular content, please don't forget to subscribe. It's on the left corner of this video. That way you will get notification if I'm uploading new videos. So let's go, right? Let us go to hypercalcemia. So hyper means anything higher than the normal range. So we talked about a couple of normal ranges that I mentioned in the previous slide. So I have two numbers here. One is measured in milligrams per deciliter, and the other one is measured in milliequivalent. So depending on the hospital policy, please look and review your hospital policy, because that's where you're going to look at whether it's going to be hypercalcemia or hypocalcemia. So let's begin. Hypercalcemia. So calcemia, by the way, is the terminology for calcium electrolyte. So what are the factors that causes hypercalcemia? So there are three things that I can think about that would kind of help you remember on what are the factors or the causes of hypercalcemia. So remember, calcium, you take it by mouth and you have to excrete it out. So if you take too much without excreting it out, then there is a tendency for that calcium level to go up, right? So hence one of the reasons or one of the causes of hypercalcemia is increased calcium absorption. So this is secondary to too much intake, either vitamin D or calcium supplements. The other cause or the other factors that for increased calcium level in the blood is secondary to its excretion. So if there is decreased calcium excretion, and usually done by the kidney, then therefore that calcium stays in the body, then you have an elevated calcium level. The other condition also, whether it's kind of like secondary to administration of a particular drug, and that particular drug is thiazide diuretic. Thiazide diuretic, patients are going to be peeing a lot, but there is a tendency for that calcium to stay inside the body. Therefore, you have hypercalcemia. Last but not least, in terms of hypercalcemia, the causes of it is secondary to increased calcium reabsorption. So this is inside the body already, and it's going back inside the body or any organ system. Usually secondary to malignancy, cancer-related hyperthyroidism or hyperparathyroidism. So what are the clinical signs? Okay, so there are a couple of myriads of clinical signs that you're going to encounter. But these are the three common systems that you're going to see, and particularly cardiovascular, because you're going to see that usually the first thing, followed by some of your neuromuscular changes, and at the same time GI changes. So in terms of cardiovascular changes, the heart rate is elevated. There is a tendency for the blood pressure to go up initially, but eventually it's going to go down and the patient's going to have cardiac arrest. So that's the problem about hypercalcemia. In terms of neuromuscular clinical symptoms or clinical presentations, it's exactly the opposite compared to hypocalcemia, because in hypercalcemia, the neuromuscular system is really a little bit weak compared to the hyperactivity when you have hypocalcemia. So there is muscle weakness, there is diminished or absent tendon reflexes. And in terms of the GI system, exactly again the opposite of hypocalcemia. This time, instead of hyperactivity, this is hypoactivity of the vowel sounds. Decreased gastric motility is not bad. It's really bad, because if the fluids or any gastric content is not gonna be eliminated quickly because there is decreased slowing of your peristalsis, then there is the tendency for that fluid to stay in the belly. And if the patient is, let's say, unable to control swallowing, or if the patient is mechanically ventilated, there is a tendency that patient is going to vomit. And if the patient is going to vomit, then the patient is going to, it's a risk for pulmonary aspiration. Okay, what are the treatments? A couple of treatments that I could think of. Of course, discontinuing the fluids, the IV fluids that have too much calcium in it. Of course, discontinuing thiazide diuretics, because we know that's one of the causes, and change that to another diuretic if a patient really requires diuretic. And of course, dialysis. The other thing that I didn't put in the slide is that hypercalcemia actually creates or predisposes a patient to kidney stone, and particularly calcium stones. And of all the stones, of all the kidney stones, calcium stones is the hardest to pulverize. So, and then most importantly, and we do this a lot in med surg and in ICN or whatever setting you have in the OR, is because the patient's bone is very brittle, there is a really high risk for this patient to have fractures. So we really have to be very careful when we're getting the patient out of bed or go to his chair or go to the bathroom, to be sure that we are really patting everything to avoid the patient from having an injury. So this is the end of our hypercalcemia lecture. Again, if you like this content, please subscribe. I'll see you again next time.